It's a pleasure to be here, and I think it's really important to have a chance to talk about diabetes care and individuals who are in residential care or long-term care. I think in all aspects of medicine we're finding that the acuity level is increasing and the complexity level is increasing, as well as patient loads and so on. And so the subject of diabetes is involving at least 25% of your patients, and probably more. And you see everything from the mild diabetic that you don't really have to worry about to patients who've had type 1 diabetes for years and are on complex regimes and everything in between. Our guidelines have, as Susie mentioned, stress the new screening approach, which is the most reliable approach, is looking at a fasting glucose and an A1C, that we seldom do glucose tolerance tests today. And the de-prescribing of medications in older people to reduce their complexity and the potential for drug interactions is important. The other thing that's been really key is the focus on individualization of care, individualization of targets, individualization of therapies. So by the end of the session, I hope that you'll be able to appreciate the approach to older people, which you work with every day, especially those who have functional dependence, frailty, dementia, or who are at the end of life. Look at some of the strategies to prevent hypoglycemia in the older patient with diabetes and their multiple comorbidities or frailty, and understand that the individualized approach to diabetes care is so important, because there are really no two people alike, and diabetes requires a personalized diabetes care plan. So what are some of the issues that are unique to older people when it comes to diabetes management? Well, often there's more of an issue with insulin deficiency as opposed to insulin resistance. Life expectancy is a key factor, and we look at it in terms of whether a person has a good 10 years to go or may have a greatly shortened life expectancy. I don't like to say to patients, well, you don't really have to worry about your blood sugar being 10 or 12 anymore. You don't have time to develop retinopathy or neuropathy. That's a very sensitive way to address the topic. But it's true that the fear of complications may be much less relevant than the fear of hypoglycemia. And sometimes getting our patients to start to orient around to that issue is difficult, because they've been very proud of their tight control for many years. Multiple comorbidities go without saying, and then there's the multiple drugs and the potential for interaction. The issue of hypoglycemia is something that patients are certainly concerned about, but I think even more so it's the staff and the people caring for patients. And sometimes fear of hypoglycemia actually gets in the way of appropriate therapy. Actually identifying the goals of care and differentiating is again a very, very important aspect. And access to appropriate resources and appropriate information is essential, and often the ability for the caregivers to communicate when they're not all in the same place. So the A, B, C, D, E's, and S's of diabetes care that we're all familiar with may be differentiated in these patients. Usually we think in terms of an optimal A1C as being less than 7%. The optimal blood pressure is less than 130/80. The optimal LDL cholesterol is less than 2. And that the drugs that we give to protect the heart include the ACEs or ARBs for blood pressure and vascular protection, the statins for lipids, aspirin for risk of coagulation, new SGLT2s and incretins and SGLP1s, exercise, healthy eating, screening for complications, smoking cessation, self-management, stress, and other barriers. So issues that we really don't even address when we talk about that is a very, very common issue, which you're starting to experience in terms of gauging the appropriateness of your therapy. Frailty is a widely used term that is associated with aging, and it denotes a multidimensional syndrome that gives rise to increased vulnerability. And this scale that you're probably familiar with is very important. And we have seniors who may be in their late 80s who are still very fit, and where an appropriate goal for therapy would be the same as a younger individual. And then as we go down this, this spectrum, we have people who are managing well or starting to become vulnerable, mildly frail, moderately frail, or even totally dependent or terminally ill. The frailty is also paralleled by problems with cognition. The degree of frailty corresponds very closely to these levels of frailty, which mild dementia correlates with the level of mild frailty, moderate dementia with the recent memory impairment, but still being able to focus, and the more severe dementia where they cannot take care of themselves at all. So, as we've always said in our guidelines, for most adults with diabetes, the goal for an A1C is less than 7%. But what has really been, for the younger patients who can reach a goal of less than 6.5 without any risk of hypoglycemia, it's now possible with some of our new agents to get people right down to normal blood glucose levels and not stop when they're just a little bit below 7. More importantly to this topic, though, are those who are functionally dependent or frail and have less life expectancy, or are at more risk of hypoglycemia, or in fact of even recognizing hypoglycemia. So I think that's also very nice that we acknowledge, because it's never been true that we had all our patients with A1Cs of 7%, but truly we knew that it wasn't appropriate to get patients as low as we were being encouraged to do, and that even the complexity of the therapy may dictate a much higher appropriate goal. So we now look at it much more closely in terms of avoiding an A1C, which puts our patient at risk for hypoglycemia. At the same time, we don't want symptomatic hyperglycemia. And at end of life, it's suggested that we stop measuring the blood glucose and just keep the patient comfortable. Now, it's interesting that there was a scan done on patients coming to a family physician's office over the age of 65, and they took in several selected primary care practices in Ontario, the first 833 patients, and surveyed them. These are the patients over 65, and found that surprisingly, even though the average age was 72, that the average A1C was still 7%. And in fact, 53% of these patients had A1Cs less than 7%. The average LDL was 1.6. 73% had an LDL less than 2. Blood pressure average was 130 over 72. 41% had a blood pressure less than 130 over 80. And those meeting both the A1C target, LDL target, and blood pressure, there was still 20% of these seniors who would do so. Now, one of the you can see that actually these older patients are doing better than the younger cohort, which were surveyed several years ago in the diabetes so-called DM scan. And that's what we know, that older patients who are still coming to a physician's office are the most concerned about their health. They even have time to exercise, and they're starting to be very conscious and attentive to their care. However, this is not representative of the population that we're talking about tonight. And in fact, interestingly, some care gaps were identified in this, because although the patients, 88% were up to date with their eye exams and 83% were up to date with their foot exams, seldom had they been assessed for cognitive impairment, for assessment of frailty, or even depression. So I think that we have to focus more comprehensively on the older patient in terms of their individual needs. So the first recommendation in the guidelines for older people is that functionally independent older people with a life expectancy greater than 10 should still be treated to the same targets as younger patients. In terms of the targets for older people, depending on their frailty index, if they're still functionally independent, with a frailty index of 1 to 3, the A1C target of less than 7% is appropriate, with the same targets for blood glucose values before and after meals. When they start to become functionally dependent, then an A1C target less than 8% is more appropriate, and we increase our goals in terms of monitoring. When they're frail or starting to have dementia, going up to an A1C of 8.5% is appropriate. But truly, we're not measuring A1Cs to determine what is the therapy which is appropriate. More on the basis of the day-to-day monitoring, you may be accepting a blood glucose up to 10 before a meal as appropriate, as opposed to getting back into that close to normal range. And at end of life, as I mentioned, you individualize, but keep the patient comfortable and stop measuring both blood glucose levels and A1Cs. There are 3 different organizations which have really agreed quite thoroughly in terms of these goals. The ADA, the American Diabetes Association, Diabetes Canada, and the International Diabetes Federation. So again, they're all, I think we have the strictest, and we're saying that those that are functionally independent still can be treated to an A1C less than 7%, but certainly worldwide the goal of less than 7.5 is accepted. When they start to become more compromised, going up to the 8.5%, you'll see that Health Canada and Diabetes Canada have stuck with that blood pressure target of less than 130/80, whereas both the international guidelines and the Americans have loosened it up to 140/80 or 90. I think that the rationale with Diabetes Canada is we've had guidelines committee between the different organizations, Blood Pressure Canada, the Nephrology Canada, etc., geriatrics, where we want to have harmonization of our targets. Truly, the blood pressure target is achieved more on the basis of the person's biology and how they respond to medications, and not because we continue to intensify the blood pressure down to a level of less than 100 over or 130/80. So when we look at our guidelines, another feature that has become new in the past couple of years is finally having drugs which demonstrate prevention of cardiovascular disease and cardiovascular death if a person is known to have coronary artery disease or congestive heart failure. They are prioritized to drugs that have been demonstrated after metformin to have a cardiovascular benefit. So this is really our biggest breakthrough, and initially the first trial to show this was the EMPA-REG study with empagliflozin, also trade name Jardiance, where it was demonstrated that there was a 35% reduction in hospitalization from heart failure, and there was a 12% reduction in cardiovascular death, myocardial infarction, and stroke. Since that time, liraglutide or Victoza has been demonstrated to have an antiatherosclerotic benefit with reduction in heart attack, stroke, and the so-called three-point MACE. Since that time, liraglutide has, or rather semaglutide, the Ozempic modification of the liraglutide, has been demonstrated to have even more potent antiatherosclerotic benefits. And we have the results of the canagliflozin or Invokana trial with Canvas and the Declare trial with dapagliflozin, showing reduction in cardiovascular events, particularly hospitalization for heart failure. So really a tremendous benefit in addition to glycemic control in selection of agents. If our patients do not have established cardiovascular disease or are at high risk for cardiovascular disease, then we have a number of other choices, and at that point we start to prioritize drugs which can reach the glycemic target without risk of hypoglycemia. And so here the medications that are standing out are the DPP-4 inhibitors, the GLP-1 receptors, and the SGLT2 inhibitors. And you can see that when we look at the column of effect on cardiovascular outcomes, then we've got the superiority with liraglutide and the superiority with the SGLT2 inhibitors with Cana and EMPA and DAPA. And then the DPP-4 inhibitors have been demonstrated to be neutral, that they don't increase cardiovascular disease, aside from some concern about Onglyza increasing congestive heart failure. And we now have drugs that can promote weight loss. Again, not as much of a concern in the elderly population, but weight neutrality is certainly an asset compared to agents that increase weight. The potency of the A1C lowering is certainly significant. So you can expect maybe a 0.6 drop in A1C with a DPP-4, where we may get 1.5 to 1.8 with a GLP-1 or a sulfonylurea or a combination. One of the major differences in the older patient is the ability to perceive hypoglycemia, so that we have patients going to the lab who may have a blood sugar of 3.2 or 2.8, and they might have gotten in their car and driven home and they didn't even realize that they were hypoglycemic, as compared to a younger person who starts to get shaky and tremulous at 3.9. So being able to detect hypoglycemia and prevent it is even more important. The patients with diabetes and multiple comorbidities or frailty should be prioritize to choose agents which will not cause hypoglycemia or to choose a less stringent A1C. The other consideration is very significant in the older population is the presence or absence or degree of renal impairment. So knowing which agents are safe to use in the patient with compromised renal failure. And usually the concern is that the drug may accumulate if the drug is excreted through the kidneys. So the important drugs in this regard, the common drug that we're using usually right through to the stage of end-stage renal failure is metformin. And here we reduce the dose proportional to the glomerular filtration rate. So we have patients that under the eGFR of 50 will be dropped down to a maximum dose of 500 milligrams BID, and getting down closer to 30, down to perhaps 500 milligrams once a day, and getting the same beneficial effects from the metformin because their blood levels are the same as they would be on a full dose with normal renal function. The fear of metformin is related to the theoretical risk of developing lactic acidosis. And fortunately, that is extremely rare. And when you start to take metformin away from an older patient, you start to appreciate how helpful it is. And often it's the difference between being on insulin or not. Having clearer guidelines as we now have as to how to reduce the dose of metformin is important. With the DPP-4 inhibitors, we have the Januvia or sitagliptin, where dose is reduced proportional to renal excretion. And yet it's reassuring to appreciate that if you miss that and don't decrease the dose, no adverse effects have been detected by accumulation of a higher dose of sitagliptin. Linagliptin or Tradjenta is one that is specifically excreted through the gut and kidney and doesn't accumulate, so it's approved even for use in renal failure. The GLP-1s, the ones that are identical to the human GLP, are safe down to dialysis dependent, and you don't have to reduce the dosage based on renal function. Unfortunately, many of our older patients don't have coverage for GLP-1s, but I'll talk more about that in a few minutes. Insulin secretagogues, we have two that I think are particularly useful. The first is diamicron or gliclazide. And this is a very potent insulin secretagogue, and you can usually get some more insulin release out of the patient's pancreas. It is not a good idea to use too early because used as a first line, second line, or third line drug, it's likely to cause hypoglycemia. However, before going to insulin or multiple dose insulin, you may still get enough benefit in terms of using the sulfonylurea that you can simplify and have good control with a basal insulin and not need to go to mealtime insulin or premix. So that is one useful agent, and if you're monitoring your patient as you're introducing the medication, you notice whether it's effective or not, and two, pick up whether there's any concern for hypoglycemia. The second one that in theory is very useful and in practice is very difficult to get a hold of are the so-called meglitinides, and the one we have is repaglinide or glucanorm. It's useful because it's excreted through the gut as well as through the kidneys, so you don't have to reduce the dosage for renal insufficiency. It's also useful if you've got a sulfa allergy, but the most difficult thing is getting it by Ontario Drug Benefit for approval. And basically the only indication that they accept is if the patient's getting hypoglycemic on everything else. And if they are, they probably don't even need it. Also, it needs to be given twice or 3 times a day. can be an advantage if a patient's a picky eater, but depending on their level of function and dependency, it becomes more of an issue in terms of medication distribution. The SGLT2 inhibitors have been incredibly useful. They are an insulin-independent mechanism of lowering blood glucose. They spill sugar from the blood if the blood glucose is over 5, but no sugar goes into the urine below 5. Therefore, they can't by themselves cause hypoglycemia. They're insulin sparing. They also do not cause weight gain and may promote weight loss. The 3 drugs, canagliflozin or Invokana, dapagliflozin or we've got 2 names for this drug and I keep blocking on it. Forxiga is dapagliflozin by itself. And they also have a combo that's Zigduo, which is your DAPA with metformin. And EMPA, all 3 can be used down to an eGFR of 45. What you may start to see more of, though, is that the canagliflozin and canagliflozin and empagliflozin have been approved for preservation of renal function, even if there's no hope of improving their glycemic control, because they no longer have enough renal function to promote that much glycosuria. But they will be prescribed now for preservation of renal function, or they may be prescribed to prevent congestive heart failure and cardiovascular protection. So you're going to start to see that dichotomy between those agents being used solely for glycemic control as opposed to the benefits on cardiovascular and renal function. When we start to think about our patients using insulin, it's been suggested that having them draw the face of a clock and show the hands at 10 minutes past 11 is a reasonable way to assess whether the person's still sharp enough to both administer their insulin and calculate doses. Our insulins separate into those that we think of as a basal insulin, and I like to say basically half of your insulin is usually coming from your basal insulin, and half of it is either coming from the person's pancreas or it's from prandial insulin. The role of the basal insulin, it should be a constant from day to day, and its main role is to suppress glucose production from the liver. So you don't want the levels high enough that if a person misses a meal, they're going to become hypoglycemic. But what we know from patients on insulin pumps is that there's a certain basal level that is appropriate even when a person's fasting, and it's also necessary. The so-called analog insulins are getting better and better, and we now have 2 new long-acting basal insulins, fortunately both covered by Ontario Drug Benefit, Toujeo and Tresiba, which have a flat profile and last more than 24 hours. So you don't need the twice-a-day dosing, and you can count on very constant blood levels. The mealtime insulins, represents what a human insulin does. It's a little bit slow on the uptake and its action is prolonged, and we're not using that anymore except intravenously. That's regular insulin or Toronto insulin. The new analogs, which include the Apidra, NovoRapid, and Humalog, have a faster onset of action, and their duration of action is shorter. So this is an advantage, but you have to appreciate that your patient will have some insulin activity within 15 minutes. So in some cases, if your patient's you're not so certain about how much they're going to eat, it may be safer to give the insulin after the meal. Or if the patient is relatively hypo before the meal, they still need their insulin, but give it after the meal. The premixed insulins, the two that we're using today are the Humalog 25 mix. An advantage of that one is if you're using the insulin pens, it comes in a disposable pen, or the Novo Mix 30. 30% is insulin Novo Rapid, and the other 70% is the equivalent of an NPH. And they're useful in terms of having the same insulin and being able to give it twice a day. And where the human premix, the old 3070, failed is it was very slow on the uptake and very prolonged in its duration of action. Whereas the newer analog premixes, such as the Humalog 25 mix or the Novo mix, have a sharper uptake. They cover the breakfast well, they cover the supper well, but miss the lunch. And it's also possible when you get familiar with these agents that sometimes you can actually use a dose at lunchtime if you're looking for tighter control. You're familiar with all of these insulin preparations, so I'm not going to go into further detail there. There's a combination medication that is available now and is on the market, which I think would be absolutely ideal for patients in long-term care. It uses liraglutide or Victoza mixed with insulin degludec or Tresiba. And it's a one pen, one injection a day, any time of the day, and you get your mealtime insulin provided through the GLP-1 and the basal insulin through a long-acting basal insulin. This agent is not very popular because for patients with coverage, they have the choice of using the new Ozempic, which is once a week and more potent. But if this ever gets public coverage, I think it's going to be a wonderful agent for patients in long-term care. Getting away from the combination of the oral agents plus basal insulin, and reducing the number of patients who would need a more complex regime. So this is interesting because both the insulin and the GLP-1 are compatible. You can put them in the same solution in a premixed pen, and the GLP-1, as I mentioned, gives you prandial control, brings the blood sugar down faster after the meal, and the insulin component takes care of your values before the meal and when fasting. So this is the example, and the titration is plus or minus 2 units at a time. One pen, one injection, one blood test a day. One of the other things we have to think about in long-term care, of course, is nutrition, and regular diets can be used. We don't need to talk about diabetic diets. In fact, diabetic diets look more and more like regular diets, healthy diets, that sort of diet you read about in your folders there. The blood pressure targets have to be individualized, particularly to avoid postural hypotension and risk of falling. Again, just summarizing the A1C goals, the determinant of competence. So our choice agents, when we get right down to it, are metformin in lower doses, DPP-4 inhibitors, If they have coverage, consider the GLP-1 and glycoside or diamicron in small doses, up titrated gradually. Our biggest concern is when it comes to sulfonylureas, the glyburide has the ability to accumulate, particularly with renal insufficiency or dehydration, and cause a hypoglycemia that doesn't just happen once, but can go on for up to 48 hours. As I mentioned, the meglitinides, referring to repaglinide, an interesting option as an alternative, but not commonly used, and primarily because of access or frequency of administration. The SGLT2s, there's some potential advantages of using them in patients who are in residential care. That prevention of hospitalization for heart failure or cardiac death, improvement of postprandial glucose without risk of hypoglycemia, and the delay in renal progression loss. However, disadvantages are very significant. These agents increase urine volume, so you have to be concerned about both the frequency of urination and the frequency with which the patient might have to get up to void, increasing the risk of incontinence. There is certainly a very clear risk of yeast infections, and euglycemic ketoacidosis has been seen in patients who are insulin deficient, and by using an SGLT2 and reducing the insulin requirement because the blood sugars are coming down, they may go into a ketoacidosis and have relatively normal blood glucose. So this is something that we're certainly seeing in the emergency departments. And finally, these patients often have an impaired sense of thirst, or they may not have free access to fluids, so they're more at risk for dehydration. So I would say that would be used in the well elderly, but certainly with caution in the functionally dependent. The new insulins, as mentioned, particularly the glargine as Lantus, or the concentrated form Toujeo, or the new Deglitec Tresiba, are certainly preferable to using the NPH shorter insulins. And basically Levemir or Detamir, I think, is going to be a thing of the past because it's been superseded by its longer acting, flatter profile. Premixed insulins with pre-filled insulin pens can be used. For those of you working in long-term care, are you using the insulin pens now, or are you still using vials? Pens, good, yeah. Much safer, and certainly very, very more practical. Regular diets, and trying to avoid, whenever possible, the so-called sliding scale with correction scales, which entail testing blood glucose 4 times a day with somebody to adjust and give those insulin doses. Now, one of the big challenges is that patients with type 1 diabetes are doing better and better, and they may progress to a level of functional dependency, and may have been controlling their diabetes with multiple dose insulin or an insulin pump, and may lose that ability to safely manage a more complex regime. You cannot stop insulin in these patients. They'll go into ketoacidosis and dehydration. But finding a safe regime which does not give perfect glycemic control but keeps the patient well is the goal and trade-off. So some of the examples that I've come across in my practice include a patient of mine, 80 years old, who's managed her type 1 diabetes for 60 years. She's a nurse. She can count carbs. She's always adjusted her dosage. And after being in long-term care for 9 months, where she was going through her rehabilitation after having her aortic valve replaced and recovering from bacterial endocarditis, there's a lot of difficulty communicating with the residents in terms of her doses, and a lot of tendency to withhold doses for fear of causing hypoglycemia. And as you know, in any of your residences, the prescriptions go to the pharmacy and then back to the facility. And so being clear about communication when there are changes in orders, very important. So in this particular case, it's interesting that St. Vincent's Hospital in Ottawa is now has a full-time endocrinologist who makes rounds on their patients at least once a week and directs the care in the more complicated patients. And clearly they have patients such as the one I just mentioned, or another one of my patients, too sick with metastatic cancer on chemotherapy to be treated at home, but they didn't want him in the acute care hospital. And he's in a long-term care facility going through this acute treatment. So as the patient, you're dealing with a complex type 1 patient in a critical setting, but now falling into your types of practice. So what is certainly preferable is if you can get them on a more stable, long-acting basal insulin, and then try and find an average mealtime dose that works most of the time, with, if there is a correction, a very, very gentle correction. Certainly getting away from the complexity of the carb counting and so on. Some of the cases that we've managed through the Ottawa Hospital with our diabetes nurse acting as a consultant and being able to contact the long-term care facility on a weekly basis. We had one patient who had pancreatitis from his alcoholism and still was free to drink as much alcohol as he wanted. He still had autonomy. And he was giving his own insulin, but as the day went on, he was no longer judging his either his food intake or his insulin intake appropriately. And so getting a fixed regime and getting some sense of control to prevent this individual from being readmitted to hospital every month. Another case we've seen, a woman with type 1 diabetes with rapidly progressive dementia, and her diabetes was always difficult to control even when she was well. And then you can have the added variable of free access to food or a comorbidity such as steroid therapy, and it goes on and on. So our preferable, I think, approach is when we're beyond oral agents, using the DPP-4s, sometimes SGLT2s, GLP-1s, or a sulfonylurea plus a basal insulin is probably one of your safest modalities of treatment. Next would be using a premix twice a day. And the last would be using the multiple dose insulin. Whenever we can reduce the number of injection times, certainly it's less of a load on the nursing staff, of course. So just to summarize, diabetes in older people is distinct from diabetes in younger people, and the approach should be different, especially when there's functional dependence, frailty, dementia, or patients with a terminal illness. We want to avoid overtreatment of the frail elderly and at the same time keep them as healthy and feeling as well as possible. So strictly avoiding hypoglycemia and trying to develop an acceptable and reproducible daily regime is our goal. Sulfonylureas certainly can be used as long as they're initially monitored to determine the appropriate dose. DPP-4s have a wonderful advantage of no side effects and inability to cause hypoglycemia. And these new long-acting basals certainly simplify giving the bottom line minimum amount of insulin required. And again, no two older people are the same, so being able to individualize and find a regime that is acceptable to your patient and acceptable to the staff. So I would welcome your comments and questions and experience, because I think I'm coming at this from the office perspective, where naturally by selection, the patients who can get to the office are still pretty competent. And the toughest patients end up in your lap or your beds. So I'd really welcome your input.
I have a couple of comments to make. Thank you very much for your talk. It certainly helps us reinforce what we are doing in the long-term care. The first point is that when people come to us from outside and to be with us, these residents have often had diabetes for a long time. And half the number of patients have target organ damage. They have toes that are impaired, ischemic, occasionally gangrenous. Their kidney functions are really severely compromised. Our pharmacy colleagues are fantastic in preventing us from doing harm to these individuals. Use of insulin is monitored by them, by the clinicians, and the nursing staff. Everybody is on board. The dietitians are struggling with the so-called diet, which often falls by the wayside because all the guilty relatives bring all kinds of goodies, and they're busy trying to kill their relatives.
With kindness.
It's hard to stop them from doing all this. But it's not unheard of for them to have fridge in their rooms. They have soft drinks, they have food, snacks, all kinds of stuff. So that is a challenge, but the unique challenge is everybody is an individual, and you're quite right. We have a lady on whom I get calls frequently, and the blood sugar is immeasurable, 31 plus maximum, and you sort of try and figure out what to do with her. And the first thing we do is to go into her room and actually remove a whole bunch of stuff. But she's quite headstrong. She used to be a nurse. The sad thing is it's not because she's a nurse, but she thinks she knows better. And she says quite disarmingly that she doesn't have long to go. She might as well have fun. In the meantime, the nurses, the clinicians, the NPs, the physicians are having quite a difficult time controlling her blood sugars. And so that's a challenge. Dementia is a big challenge. And the reason is you had a meal, and you forget within half an hour that you had some food.
Mhm.
Right? So we have hyperglycemias on a routine basis. The frail elderly often stop eating,
Mhm.
and you have to monitor their blood sugars very carefully. And I have seen repeated episodes of frailty-related hypoglycemic episodes. And it's nice to see them eating, but the optimal glycemic control is hardly ever there.
Sure.
I could go on and on, but I have to say the long-term care offers unique challenges. But we have help from our specialist colleagues, and that really works well. We don't use diabetic clinics in long-term care and send the patients out.
No.
All the families would much rather have us do the job.
Sure.
I think we are doing a great job. Wound management has become a specialty, and the nurse practitioners are free to do whatever they're doing and managing the wounds beautifully. That is a very good, it's a challenge that a lot of long-term care facilities do not meet easily. We try and avoid amputations and surgeries by sending people to vascular physicians who give us very good prompt care. But I think the medication mix and the comorbidities people present with, it's a real challenge. And most of all, talking to and communicating with our power of attorneys, the relatives, and the patients become very important. The newer agents are fantastic when you talk about cardiac disease and diabetes. Amazing. The glyphosins are just spectacular in what they do.
I certainly appreciate Dr. Patel, and I very much respect your experience. This is a very, very difficult, and it's getting more and more complicated area.
We provide in-house foot care as well, and so our management of feet is very important, and it works quite well. Thank you.
Is there a prescribing for statin at this point at a certain time in life, or?
That's a really difficult question, and it's a good one. If if this person were to have a stroke or a myocardial infarction, and it would have them move from one level of independence to dependency, it's still worth treating. So they tend to hang on to the statins quite long, because they're always at risk for another acute event. And it could be peripheral vascular or cardiac or stroke. We always say, though, anybody that's been in the Heart Institute will come out with 80 milligrams, and most of us are either going to have a heart attack or develop a cancer before we die. So yeah.